Welcome to Three Plastic Surgeons and a Fourth. My name is Dr. Lawrence Tong. I'm joined by my esteemed colleagues, Dr. Sal Pacella, who is in La Jolla, Dr. Sam Jejurikar, who is in Dallas, Texas, and Dr. Sam Rhee, who is in New Jersey. Gentlemen, please tell all of our audience what your Instagram handles are. Sal?
At San Diego Plastic Surgeon.
Dr. Jejurikar?
At Sam Jejurikar.
And Dr. Rhee?
I'm at Bergen Cosmetic.
And I'm at Yorkville Plastic Surgery. All right. Today we are going to talk about a very common subject, and that is uneven breasts. But before we do that, we're going to start with our disclaimer. So, Dr. Pacella, could you go over that, please?
Yes, sir. This show is not a substitute for professional medical advice, diagnosis, or treatment. The show is for informational purposes only. Treatment and results may vary based upon the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other qualified health provider. With any questions you may have regarding medical care, never disregard professional medical advice or delay seeking advice because of something in the show.
Thank you very much. So we'll start with talking about asymmetric breasts or uneven breasts. So there's a variety of reasons why that may occur in a woman. It might just be due to genetics. It might be due to weight fluctuations. It might be due to injury. It might be due to previous surgery. So I just want to start by asking on the panel, what is your approach when somebody comes in and they say, let's start with Dr. Rhee. Dr. Rhee, my breasts don't look even. How can you help me? Okay, what was...
I don't know. It sounds like watching something on his phone or something, I think.
No, sorry. I just got a text. No,
it's all right. Anyway, when someone comes, this is very common. So as we know, over 80% of women out there have some sort of degree of asymmetry to their breast. And when I see someone and they're interested in doing something about it, I usually ask them first, how impactful is the breast asymmetry to their life? Is this something that really impacts their self-esteem, what they do on a daily basis, the clothes they wear, are they avoidant of certain activities because of this? If this is the case where this asymmetric breast condition really on a daily basis impacts their life, then it's something worth exploring in terms of treatment. But otherwise, for a lot of patients, I will let them know if this is not something you think about all the time, maybe this is something you think about on occasion, it's not something that's particularly impactful, then you should take comfort in the fact that a lot of women, more often than not, have asymmetric breasts.
Dr. Jejurikar, when you examine a patient, how do you go about that? How do you assess and formulate what you're going to do?
So I think it's important to talk to the patient and get a sense as to what exactly is bothering them. There's different ways, first of all, that you can have asymmetry. It can be a volume mismatch where one breast might be bigger than the other. It can be a shape mismatch where, one breast is droopier than the other. You can see certain, you had mentioned some congenital anomalies like a tuberous breast where the actual lower pole of the breast looks very different. So the first thing is to really have a lengthy conversation with the patient about what the degree of asymmetry is, what we consider to be a normal range of asymmetry, and then how are we going to approach it. I think, the two basic ways in which you're going to deal with it is you're going to deal with volume. Either you're going to make a bigger breast smaller or make a smaller breast bigger. And then shape, if someone has a congenital anomaly where one breast is droopy and the other is not, you might talk about doing a unilateral breast lift on one side or even bilateral breast lifts on both sides and try to figure out, how to make the shapes look different. I think if someone has a gross degree of asymmetry, you can do a lot to make them look much more symmetric, but no one's ever going to be perfectly symmetric. You guys have all heard the saying, breasts are sisters, not twins. And it's important to have that conversation with the patient as well.
Sal?
So I think invariably what tends to happen is when patients come in for issues related to asymmetry, I agree with Sam, it's about volume because most of the time they're seeking a breast augmentation that in the setting of this asymmetry. So now we're dealing with a situation where, you have you have asymmetric breaths, and then you're adding volume to that through an implant. And 9 times out of 10, that asymmetry is going to get worse if you add volume, right? So it oftentimes, like if one nipple's pointing one way, one's pointing the other way, you add volume, all of a sudden they kind of point in different directions at a greater degree. So addressing that asymmetry is key. And, I think one of the more challenging issues is lifting a breast or making a breast symmetric when one look correctly proportionate. So when you have sort of a youthful looking breast on one side and a droopy breast on the other side, oftentimes that means a periareolar incision, an incision around the nipple. And patients sometimes are not prepared for that when we start the discussion because, sometimes they just think, well, there's got to be something you can do with minimal access incisions. And unfortunately, there isn't. So the act of placing that scar around the nipple, oftentimes long-term can make the nipple wider. So you have to account for that time component of things.
I think that sometimes, and I'm curious to see what you guys think about this, patients' acceptance of asymmetry is sometimes greater than our acceptance of asymmetry. Meaning what Sal was just saying, sometimes they'll say, look, yeah, I know my nipples are slightly uneven. I'm okay with that. It doesn't bother me that much. I really just don't want those additional scars. I see that all the time. Do you guys see that too?
Yeah.
I do see that. I think the funny thing is that a lot of patients accept a fairly high degree of asymmetry that they don't even notice on their body to begin with. When I see patients not specifically for breast asymmetry, but for breast augmentation, I will point out, do you see how different one side is from the other? And they're like, oh yeah, I do, but I never really thought of it. And I think that's really important when you're doing any kind of breast procedure because they will notice afterwards and scrutinize. And like Sal said, you add volume, that disproportion can be magnified to a certain degree. And if that's the case, it's very important to talk to the patient and let them know you are starting with a certain degree of asymmetry and to point that out to patients. And as Sam said, a lot of times you're like, oh, okay, well, I never really noticed it. It's not really a big deal. That's not something that is a concern of mine.
Yeah, I think that's very important. I would say that when I see a patient, my general concept and schema when I look at them is the breasts are different size. So sorry, if they're different sizes, what does the patient want? Does the patient want to make the small one bigger or the bigger one smaller? And then if they have drooping, address that. If sometimes patients will have both things, so you'll have to discuss, lifting and changing the size. So if you're lifting and augmenting, that's usually a breast lift and an implant. If you're looking at lifting but also making smaller, then that's a form of breast reduction. So there are multitude of operations that you could do and many different permutations on how to handle them. And the points about plastic surgeons being more critical about symmetry, I think is very true. A lot of times, a thing that I see is that patients come in and they want to get a breast implant and they think that's going to lift their breasts. Can somebody comment on that?
Yeah. So to some extent, I think sorry guys. To some extent, I think that can lift your breast if you're deflated, right? So if, one of the things I start to do, or I do it in my initial evaluation, is do some measurements, right? And, we're all sort of taught the measurement from nipple to nipple and nipple to sternal notch. And, for our viewers out there, that should be about an equilateral triangle. And I think when that distance from the nipple is down a centimeter or two, or you have very, very mild ptosis or breast droop, oftentimes adding a small implant or a modest size implant can lift the breast in an appropriate position. I think the key, or lift the nipple in an appropriate position, I should say. But I think the key is looking at the breast parenchyma. So when I evaluate patients, I say to them, well, we got to look at all these measurements here, and I'll give you an honest opinion as to whether I think you're going to need a lift after an augmentation of a particular size. And so, it's completely variable in every patient.
What do you think about
Yeah.
fat grafting in these techniques? If a patient's like, I don't want any implants, I just want to correct everything with my own tissue and make it natural.
I do a lot of fat grafting. I think you have to set appropriate expectations for fat grafting. I think with fat grafting, the amount of volume enhancement you can get is typically much less than you can get with an implant. So my general cutoff to a patient is if everything goes well and you get maximal fat graft taking, you'll get half to a 1 cup size enhancement. The other thing is the shape of the breast is going to be different. A lot of patients come in, they like that round upper pole look that you can get with an implant. Even in my best fat grafting cases, that are the ones that I'm really proud of, I don't get that same look. I get a much more natural look than if somebody wants that upper pole fullness, they're still going to need to use bras to do that. But I think fat grafting is a very useful adjunct, particularly in cases of minor asymmetry where you're doing a breast lift. I have found that I can correct for that pretty nicely and create a look that's pretty darn symmetric afterwards without having to use an implant.
I think one of the most amazing things with fat grafting that I've been able to accomplish in my practice is, kind of alludes to what Sam said about, everything's big, what you essentially said was everything's bigger in Texas, right? Everybody likes that little, but here in San Diego,
everybody. I said some patients like that. Not everybody likes that. Some patients like that.
So,
His definition of some is 90%.
Right,
No, that's not true. Don't fall into stereotypes, guys.
So, I tend to see a lot of kind of athletic type women, soccer moms, yoga mom type of look, and they're looking for fullness on the lower pole, a little bit more natural look up top. And I think, the sort of combination of lipo filling the upper pole is a really, really excellent option for them because we can get a very nice natural slope up top, but really kind of work on the projection down below. The other thing I think that has really, I've really been very hot on in my practice the last few years is, when you talk about where we place the implant, I think most of us still place the implant submuscular underneath the muscle, and there's some data behind that, right? There's definitely a reduction in capsular contracture rates, but I think that comes with a little bit of a cost. Oftentimes underneath the muscle, we're not able to get really extensive cleavage or sharp cleavage. And the implants oftentimes have a lateral displacement and inferior displacement. When you fire the pec muscle, pushing everything out. So what I have been doing is adding some fat transfer to the medial pole pretty extensively at the time of surgery. And I think that works phenomenally because it still allows us to keep the implant under the muscle, but really work on augmenting the cleavage.
And it can hide rippling and it can help with animation deformities too. Yeah, I agree. I do that a lot too. Sorry, Sam, you're about to ask a question.
I was about to ask, how often do you do combined fat grafting / implant? Well, it sounds like a lot of your cases now are breast aug with implant plus fat grafting. How about mastopexy and fat grafting? How often is that done? Or all three, breast lift, fat grafting, and implant?
I think it's a bit of a challenge to do all three in one sitting, particularly with the extent of the mastopexy that you're doing. If I'm just doing a little bit of a small lollipop type of lift, it's fairly easy and safe to do fat transfer. But the problem sometimes is in older women, 60s, 70s, and, they just don't have a lot of natural architecture to your breast. And we're really doing a much more aggressive mastopexy. I think it's tough to do fat transfer with that because, when you're peeling off all of the skin of the breast and reshaping the parenchyma in the setting of an implant, you're really relying on pretty dismal blood supply. Anyway, and then adding that fat sometimes can damage the blood supply. I don't know exactly where to put it sometimes because it's just not a great space to put it in. So it really depends on the extent of the mastopexy.
How many of you guys, I'm assuming you guys usually do this, but I would say 99% of my breast lifts and augmentations simultaneously. I remember when we trained, a lot of people would advocate doing this in 2 separate operations, but the reality is patients don't want to do that. And I think it's important to let patients know that, that makes it a harder operation because you're putting an implant in. That means you're stretching the skin out. And then you're doing a lift, which means you're removing skin. So the combination of, successively making the skin envelope more stressed, you have more issues with blood supply, as Sal just said. You have more issues with potential for asymmetry or creating asymmetries. You have potential for more scars. But having said that, I think that, most cosmetic surgeons will do it as a one-stage procedure. There are various methods to do, ranging from periareolar, which is an incision just around the areola, to a lollipop incision, which Sal had mentioned, all the way to an anchor incision. But I'm just wondering, for you guys, what is your general approach to breast augmentation and lift simultaneously?
I will say that probably 85-90% of the time I do it in one stage. But when the degree of droopiness is pretty significant, I quote patients a much higher rate of a complication where the implant might bottom out. The tighter the mastopexy, the more things will stretch out, just like you've said. That being said, that still amounts to 2 operations, and during that one operation, they generally look better in their clothes and they have a shape to the breast that they like better. So I do it more often than not. In really severe cases of ptosis or droopiness, I might think about using an implantable mesh material to try to help prevent that. I get a different complication then, called the waterfall deformity, where the tissue can fall over in really severe cases. So there's no risk-free way to do it. But I think a good rule is the more severe someone's droopiness is, the higher chance that they might have a complication related to the implant or recurrent droopiness afterwards, if you do it in one stage.
I generally will do them in one stage. I think what I will do in 2 stages is if they have an implant already in place and they want that out and then they want to lift with that. If the patient is amenable, I will generally take out that implant and then go back and do a lift secondarily, because I feel the results, you can get a tighter mastopexy if you allow that implant to be removed first. Yeah, and you just get, to me, it's always like doing a tummy tuck like one day after delivering a baby. Like, what's the point? Like, everything is just so stretched out. Not all patients feel like that's something they want to do, but I think the results are better, at least in my hands, in those cases.
So is that in the cases where you're not replacing an implant?
Correct, where they want an implant out and then they also want to lift.
See, in that scenario, I would do it in one stage, but I would aggressively fat grap that breast a lot of the time to try to fill up some of that volume. I typically do it almost always in one stage.
How much fat do you feel comfortable grafting in one shot, volume-wise?
I mean, it obviously comes down to characteristics of the patient's breast. So you look for things like the turgor or the tightness being a lot more. You look for redness or erythema developing in the breast. But in general, I might do up to 300 or 400 mLs in one stage. I've done more than that too, but 300 or 400 is per side. I use the Viality system that came out about a year ago, and my rates of fat necrosis have gone way down using that system.
It's a great system. Great system.
I use that in all my breast fat grafting cases, and I like it a lot. Let me change the focus just for a second, because the scenario, going back to the original topic, which was breast asymmetry, the scenario I see this the most in are patients that are coming in for a breast augmentation consult. So you guys want to talk about, like, you see a patient, you see some degree of asymmetry between the breasts. They're in your office for a breast augmentation. How often are you using asymmetric implants? How do you determine the appropriate way to pick asymmetric implants for a patient if you're going to do it?
So I'll start off by saying that if I'm doing an operation and we're also doing a lift at the same time, then I will always recommend symmetric breast implants, because I believe that you can adjust the volume just by removing breast tissue at the time you're doing a lift. But if patients have significant volume differences, you're going to have to talk to them about different breast implants. And I think actually that's one of the hardest things to be able to estimate properly, because for the viewers, as you increase the size of an implant, so if you have two different size implants, it's not just the projection, meaning how much it sticks out, that changes. It's also the base width, which is the diameter of the implant changes. So right there, you're already introducing another variable which can affect the symmetry. So when I'm in these scenarios, usually what I'll do is have patients try on implants using a bra and trying to get an idea of what size works the best with combination, but also counsel the patients that it's not guaranteed to be perfectly symmetric. There's a likelihood that there's going to be some residual asymmetry afterwards. And I find that if they understand that and you go through it with them, then they're very accepting about minor asymmetries that may exist afterwards.
I agree with Larry. I think the base diameter, if they're markedly different from one side to the other, that can be a real challenge in terms of sizing appropriately. Some of it is just experience at this point. I know what I feel comfortable in terms of how much of a difference there has to be in order to change sizes or profiles in terms of one side versus the other. I generally say patients are fairly conservative. They don't necessarily want they're pretty accepting. They generally will accept minor differences as long as it's better or much better in terms of their asymmetry. And so some of that, as Larry says, I try different sizers. I do some pretty careful measurements, and I really try to get a sense of the patient's goals in terms of how close they need to be. And as Larry said, if you're doing a mastopexy at the same time, it's a lot easier to correct for volume differences at that point.
Just to clarify, when you say you use sizers, are you talking about intraoperative sizers or preoperative sizers?
Both.
For me, I use only preoperative. I rarely use intraoperative.
I always use intraoperative sizers. I think it. I don't know how I could choose an implant without that. And I will say, in doing a ton of breast reconstructive surgery in the setting of mastectomy, that's an absolute necessity to have a sizer. There's so many differentials in size and consistency, profile, etc. Getting back to the concept of what Larry was saying about using symmetric implants. So I agree with you, Larry. When I'm doing a mastopexy aug, and there are slight asymmetries in the breast in the setting of the lift, I'll always try to use symmetric implants and try to account by removing some breast tissue and sculpting it appropriately. If it's a unilateral situation where I'm doing an aug on one side and an aug pexy on the opposite side, in general, a good rule of thumb I use is one profile difference to account for the mastopexy. So, for example, if I'm using a high profile on the non-lifted side, I'll oftentimes use a moderate plus profile on the lifted side.
I totally agree with that. And I use intraoperative sizers a lot. Even I'll use intraoperative sizers in a case that I think was pretty symmetric at a time. I just like being able to assess the patient with sizers before I put in the definitive implants, make sure my pockets are dissected the way that I want them to do. I use them in probably close to 100% of my cases. But I think it's just difference. We all have differences in how we like to do things.
I think the issue is that sometimes you really want to try to have the patient make the decision on the size, and that I think reduces potential issues afterwards. Because if it's your responsibility to put the implant in, sometimes they can come back and say, "Well, this is not what I wanted. You decided this. I want to get them changed out." And so I find that going through the process preoperatively and getting them to sort of make a decision on the size helps a lot. Now, of course, if there is a significant asymmetry, yes, then I will use intraoperative sizers, because I won't be sure necessarily how it's going to look until I actually am doing the operation. But I think that if it's relatively symmetric, I don't I don't like to use intraoperative sizers, mostly because I think it adds extra time to the surgery. And then also, the onus is sort of put more on the surgeon than on the patient. And I think ultimately the patient should be the one who decide what implant size they want.
I think those are mutually exclusive concepts, though. I think that I have the patients, I use 3D imaging and the patients pick the sizes, but even if I think they're symmetric, I'll use sizers to make sure that my pockets are dissected the way that I want to. I'll take them out. I'll wash the pocket again one more time, and then I'll use a Keller funnel. And that way I'm not manipulating the pocket at all when I put in the implant. And I'm not doing any sort of that last minute digit dissection that people will do. And again, I have patients always pick the size ahead of time, but and it's not that I necessarily am using sizers just for the purposes of assessing asymmetry. I just think they have, in my practice, a pretty valuable role in making sure that things are looking exactly what I want to before I commit to the final implant. But again, you talk to 100 different plastic surgeons, we'll all do different things, and we all think we're right. So, like, that's the great thing. We're an arrogant group who think our way is the best. Well, do you guys have anything more you want to add to this topic? I feel like we've done a pretty good job of talking about all the nuances that are actually present with breast asymmetry cases.
Yes, I agree. Great discussion, guys. Thank you all for all the viewers watching and listening, and we will see you at the next podcast.